Welcome back to Healthcare Rounds. I'm John Marchica, CEO of Darwin Research Group. Our guest today is Vinay Patel, founder of MakoRx, and holds his doctorate in pharmacy, has been working in the pharmaceutical industry for more than 20 years, and he's no stranger to podcasts, so that's great for today. What I'm really excited to talk about today, hope you're excited to listen to it, is to get a better understanding of drug pricing. And we've talked about this on the show before. It's been quite some time, but as you know, kind of looking at some new models that are coming out, even new distribution models, new manufacturing models, I think it's great to kind of, get a beat on where we are today and with some of the new innovative companies that are out there. And I think we could probably put MakoRx into that. So without further ado, Vinay, why don't you tell us a little bit more other than, a little bit that I gave there, a little bit more about your background and what led you to be doing what you're doing today.
John, thank you so much. It's an honor to be invited to your healthcare podcast. Heard a couple episodes and excited to have this conversation and share ideas. So really looking forward to it. I got into pharmacy benefits as a pharmacist. As you mentioned, I've been a pharmacist for about 20 years now. Worked in various different areas of pharmacy, whether it's health systems or academia, teaching medical residents and pharmacy students and pharmacy residents about how pharmacy works, or working in medical offices and setting up pharmacy clinical services or pharmacy practices, and independent pharmacy and retail pharmacy. It's throughout all of this, and you probably heard similarly from medical colleagues, is that the pharmacy benefits industry just hangs over your head wherever you practice as a pharmacist. And they get to dictate what money you make as a pharmacist to dispense medications, what you get to tell your patients sometimes, and how, what kind of care they receive, so on and so forth. They're sort of this infrastructure that you have to work through. And what exists today, or what had exist before we created MakeRx, was these three large PBMs that have only gotten bigger and control 80% of all prescriptions in the country. And it was like there was chocolate, vanilla, and strawberry. And we wanted to come into the market and say, look, we're going to bring gelato. It's going to be a completely different model. It's going to be cost plus. And we're going to create an infrastructure that helps you get medications through local pharmacies, a network of local pharmacies, so you don't have to wait in the mail for drugs. Nothing special about getting your drugs in the mail, because most of the times you're pushed there because of ownership reasons. The insurance company or the PBM owns a mail order specialty pharmacy they want you to go get drugs at. And so that's really what created the inception of MakeRx, is just, one, partly a frustration, and two, just creating a new model that hadn't existed specifically for employers in the commercial market. We go with employers, work with them, help them understand, all the details of their pharmacy benefits program, and then tell them there's a different way they can be doing things if they wanted to get more transparency and savings.
Well, we'll talk more about that and about how you do that here in just a minute. But I think it would be helpful to start off by, from your perspective, just walk us through the drug pricing model. Everything from, if I'm Pfizer or whatever, some big drug company, and I've got to get my drug out there. And also, as you're talking through the pricing model, maybe start off with like the base, the simplest, model. And then once you start getting into injectables or other things in office, kind of like how that pricing may change. But so before you
Yeah.
start talking, this is a warning to everybody who's listening or who's watching on YouTube, whatever. I'm going to ask for a level of detail than maybe maybe you're not accustomed to. Hang with us for a few minutes and just listen, because it's been my experience, and we are talking about this just before we got started, that it's one of the areas of healthcare, just pricing in general. But when you get into drug pricing, that some of the more complex, it's so much so that a lot of people, even in pharma, a lot of people that I work with in the pharma biotech industry don't even understand how a product goes through, how it's priced, and how eventually someone gets it. They're more interested in, features, benefits, clinical profile, all those kinds of things. And even if there's a price, my sense is that pharma kind of just looks at price as an objection to overcome. Yeah, the price is
Mhm.
what it is, and we're
Yeah.
gonna talk about that with the pharmacy director or the doctor or whoever is the end user, without really thinking about how this. And I think understanding, I'll say this last piece before I turn back over to you.
Mhm.
Understanding the pricing, is really important because I think in general, I will say pharma is not valued, or the drugs as part of the overall spend in healthcare.
Mhm.
It just generally
Mhm.
tends to be one of those things where there's a spotlight and says, "Oh, you're charging too much," or "We don't understand how pricing works and it's bad pharma," and all. It's been my contention that pharma needs to do a better job of explaining the benefits that accrue to having that as part of the overall pie. And maybe you want to spend more on pharmacy. Maybe the pharmacy budget is too small in your health
Mhm.
system or in whatever.
Mhm.
So I've said enough setup. I'm going to turn back to you, Vinay, and just walk us through the typical step by step how drugs are priced and who's involved in the process.
Okay. Um, I want to hit on something that you mentioned at the end of what you just set up here in terms of the there's two philosophy, but we'll get into we'll get into all of that, how drug pricing works, and there's going to be a whole
Right.
lot lengthy explanation there and conversation around that. But just
Sure.
want to hit on this. There's two camps that I see from a pharmacist perspective. One is we need to get drug prices as low as possible, and everyone's attacking the price. And as you mentioned, there's a spotlight on these prices of drugs. Well,
Right.
there's a floor here, and if we start going below that floor, we're going to start seeing pharmacies close. We're going to start seeing options, healthcare options, dwindle down to maybe one or two options that are available to patients, and that's just not good for anyone. So there's this commodity view of a drug, and that's just get the price as low as possible. And we have supply chain issues, and we have these drug shortages that are linked to just trying to get the bottom dollar price. And then there's this, hey, pharmacy is a component of the total cost of care. It's contributing to how healthy or how sick people can be, depending on if they're on the right drugs and if they're taking them, and so on and so forth. And they contribute to downstream costs like healthcare costs and surgeries and the weight and the burden that chronic conditions have on society and these health systems, and so on and so forth. And so it's really complex. It's a complex web. And I really like to help employers understand that pharmacy is just a component of this healthcare landscape. And if you just want to view it as a commodity, well, we're going to have a separate conversation. You may want to deal with a different company, because we're really trying to show you the value of pharmacy and show you the value of drugs in keeping your population healthy. And so,
Makes
just on
sense.
that context, let's there's there if we're going to try to outline drug pricing, we have to start with, in my opinion, start with where the drugs come from. And you mentioned, if we're going to talk about some of these drugs that are available from a drug manufacturer like Pfizer or Lilly or Novo Nordisk, these are typically what's called brand medications, and they're the manufacturers. So these companies, Pfizer, Lilly, Novo Nordisk, they're manufacturers. They're making these drugs in uh, quantities of tens of millions of units. And to get this medication to a pharmacy, for John to walk into his pharmacy and get it from his local pharmacy, there's a supply chain, a distribution chain, if you will, to get these drugs. So the drug manufacturers cannot distribute to an individual pharmacy. They're just not built for that. They're built for manufacturing drugs and mass producing them. And then they go through this channel partner called a wholesaler, a drug wholesaler. There's, again, consolidation in that market with companies like McKesson or AmerisourceBergen that supply that wholesale warehouse these drugs. So they're going to warehouse from the tens of millions that get produced, tens of thousands of these medications. And then John walks in with a medication need into his local pharmacy, and the pharmacy says, okay, I need one of these these drugs, one of these whatever drugs, Eliquis or Aimovig that John needs for his condition. Okay, great. Insulin. Let's get that insulin off the shelf, get it to that pharmacy because there's an order from the warehouse. So that's the supply chain side. That's the drug manufacturer having one manufacturer manufacturing one medication that's typically tied to when a new drug comes to a market to one manufacturer, gets to a wholesaler, and then that wholesaler distributes it the one or a small quantity to a pharmacy. And in that flow, the drug manufacturer, the pharmaceutical company, is setting the price for that medication, and then the wholesaler has a certain markup, and then they sell it, and then they sell it when they sell it to the pharmacy. So
Okay,
that
so let me interrupt you. So
yeah.
listeners, stay with us. So in the simplest example, um, you have manufacturing facilities
Mhm,
at let's say we use a specific example. So Eliquis, you
mhm,
mentioned that. That's BMS, is that right? Or Merck? Let me get that. I should have that right. The manufacturer of Eliquis
yeah.
will then send bottles of 100, whatever it is. Those go to McKesson, Cardinal, the various distributors.
Mhm,
They warehouse different distribution.
mhm,
Maybe they have different distribution models. Maybe one's a FedEx model, one's a UPS model. Who knows?
mhm,
Then that goes out to the Walgreens of the world, as well as to the independent pharmacy
mhm,
down the street
mhm.
from that one place. So that's the supply chain. Now, what about, people are going to ask, what's a limited distribution
Yeah.
network, and how do those come in? And are there exceptions to the, I'm shipping everything off to McKesson, and then McKesson is going to ship to the local Walgreens or the local pharmacies?
Mhm.
So what would be that limited distribution?
So a limited distribution drug is a medication that's only supplied to very few pharmacies, typically less than 5 pharmacies in the country will have access to a limited distribution drug. They're typically what's called specialty medications or injectable medications, special storage and handling requirements and administration procedures for these specialty medications, or treat what's called an orphan drug, which treating a very, very small population of the country or the world that have this specific condition, and they're only supplied through a handful of pharmacies that can get it. Typically, it's a specialty pharmacy that will mail the drug anywhere in the country. And there's, again, these 2 or 3 big specialty pharmacies that will typically have access to a limited distribution drug. You won't be able to get it from your local pharmacy or from any pharmacy that you would want to get it from. You'd have to go through this specific channel to get that drug.
And who owns the limited who owns these giant specialty pharmacies?
The biggest ones are owned by these pharmacy benefit companies. So the big 3 pharmacy benefit companies have their own specialty pharmacy divisions or specialty pharmacy locations that distribute these drugs. CVS Caremark has their own Caremark specialty pharmacy. Cigna Express Scripts has their own Accredo specialty pharmacy. Um, and then, Optum, United Healthcare have their own specialty pharmacy as well.
So, and I know we're going to get to PBMs in a second, but so the PBMs actually have the lion's share of the specialty limited distribution in
Hmm.
these networks,
Hmm.
but they're not warehousing or distributing conventional medications, which
Correct.
go through McKesson and so on and so forth. Okay.
Correct.
So
Correct.
I'm tracking with you, and I'm hoping our audience is. So next step. So we got the supply down, the supply side. Yeah. Oh, there's one other scenario, distribution direct. So
Uh-huh.
does Banner down the street from us here in Phoenix,
Mhm.
do they buy anything directly from BMS or Pfizer or Merck or anything? Do they actually buy directly where they would be shipping directly to a hospital or to a pharmacy?
They're for the most part, no. They're buying it through the same sources. There's medical distributors or medical wholesalers that stock some of these drugs that, like, similar to Cardinal McKesson. They'll be well warehouses, wholesalers that will distribute drugs to the health systems as well. And they're ordering it from a warehouse that will distribute it to them as well. There's a very small group of direct buy drugs, mainly specialty medications that will be bought on a one-off basis directly from the manufacturer. They're typically, very specialized medications that would go directly, and that's where the wholesaler will set up a distribution model that goes direct to a health system.
So there might be an argument for a specific drug that has some specific handling or whatever. The company, or it may be very, very rare, a very limited number of patients.
Hmm.
So the manufacturer may say, we want total control.
Hmm.
And wherever the care is being delivered, they want to share in that control with the manufacturer. They don't want anybody in the middle of all of that. And so there might be, but as to your point, it's very rare that that happens. For the most part, it's either going directly to a regular distributor or to a specialty pharmacy
Yeah,
aggregator that then
that's right.
ships out. Okay.
That's
All
right.
right. So now that's the supply side.
Yes, and the key piece there is to note that that's the purchase price for the medication. So the price that the pharmaceutical company sets, that the wholesaler buys from, and then the wholesaler sells it to the pharmacy. The sort of the summary here is on the supply chain side. That's what the pharmacy is buying the drug for. So that's the purchase price, and we're just going to put that on the side, and we're going to move on to how does what determines the price of a medication? That's just what the pharmacy bought it for, and that's one price. And we have dozens of prices in pharmacy, and we can get into why there's so many different prices. But on the other side of this coin, if you will, is the contractual side, which means that you now have a pharmacy benefit company sitting in the middle of what we traditionally called plan sponsors. That could be a government entity. It could be a federal entity like the VA system. It could be the Federal Employees Health Benefits Program. It could be a small business that's in and around Phoenix with a couple hundred employees, or a large business like Boeing or American Airlines that buys benefits for their employees. Those are all plan sponsors. State, local, county government, school systems. Those are all plan sponsors that work. Their desire is, I want to offer benefits to my employees. How are we going to facilitate that? We need to figure out how, when a member walks into a pharmacy, they will get access to the drugs and the benefits that I set up for them. Well, we need to go find or hire a pharmacy benefit company to facilitate and administer the complexities of what we're going to do with every single medication that's available out there. And so that's a contractual relationship. The plan sponsor could be any one of these entities that we've talked about, contracts with a pharmacy benefit company. And then that pharmacy benefit company has contracts with pharmacies. And they have pharmacies that they own, that they manage, specialty pharmacies, mail order pharmacies. They have pharmacies that they don't own or manage, that they contract with directly, like independent pharmacies around the country or grocer chain pharmacies, or these big retail chain stores like Walmart and Walgreens and CVS, so on and so forth. So they're contracting with these pharmacies to say, hey, big employer group or school system or county, state healthcare, state health plan employees, you have access to all these pharmacies in our network that we've contracted with, and they all have that contracted rate is what either the plan sponsor is going to pay, and a portion of that is what the patient or the employee is going to pay when they go into these pharmacies. Now, there's a third special relationship that these pharmacy benefit companies have, and that's relationships directly with manufacturers. And that's when we get into the conversation of rebates. So now you have the purchase price through the supply chain side that people are buying it from, and that's sort of this list price. Off that list price gets a rebate that's passed on to these pharmacy benefit companies that offsets the price of this medication. And now is where this contractual relationship with the pharmacy benefit company sitting in the middle between drug companies and getting rebate dollars for these medications, the plan sponsors, what they're paying to get a patient to have access to this network of pharmacies and getting a drug at a local pharmacy, and then what they pay the pharmacies also on a contractual basis for these same medications. And that's really where the web gets complicated here. And I'll stop there just to make sure I'm not getting too off track.
No, you're on track. And so if I'm an employer, now this is bad for Darwin, this is a bad example because we're a small business
Hmm.
and we just buy into whatever Blue Cross Blue Shield of
Hmm.
Arizona, which is our health plan that we have some choices from them that a
Hmm.
benefits company has given us, which includes drugs and dental and all that other stuff. But we don't have the buying power or the say so to go create something on our own, like an American Airlines or
Hmm.
a Boeing or somebody or even a company with 1,000 employees would be able to do.
Mhm.
So if as an employer, pretending I'm a benefits manager for one of these larger employers, what I want is my employees to be happy and I want them to be healthy. And so, but there's a trade-off, right? So maybe I'm offering some different options for the people who work in my company to say, well, I want the Cadillac option that,
Mm.
or I want this company, or I'm young and healthy and I don't want to be paying for a bunch of stuff I'm probably never going to use. I want the cheaper option with a higher deductible or whatever. But the point is, when you say plan design, the benefit manager, whoever's in charge of that, or if it's outsourced, is going to determine a mix of healthcare benefits, of which pharmacy is a component.
Yeah.
And the pharmacy component, there may be options there, or maybe it's the benefit manager is deciding on, I'm going to use this CVS Caremark, whatever, this particular plan design.
Mhm.
And in that, there might be, just to simplify things for the audience, there might be access to every drug possible for next to nothing in terms of a copay, or there may be on the other end of the spectrum a very tight window list of drugs that they'll pay for or that your employer will help pay for, um, and very little selection, and that would be maybe more on the cheaper end of things. So the design has to, I would imagine that in the PBM design for a pharmacy benefit is going to look similar to a traditional health benefit. You with more products available for zero to no copay versus a more stringent kind of list of drugs. That's kind of what the PBM is doing, putting those lists together and then contracting for rebates. So the PBM,
Mhm.
this just struck me. I don't know why it didn't. PBM is making the same argument as a GPO, right, Vinay? I mean, essentially, it's like we 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 have a lot of buying power because we
Mhm.
have a lot of people
Mhm.
who we're representing through these plans, and
Mhm.
therefore we can negotiate better pricing for people. Is that right? Or am I getting ahead of the game here?
So it's better rebates. And that's the piece that really trips people up is that it's funny that you would think that a larger population or again, the point I always go back to is it seems like nothing in healthcare follows the laws of economics. It seems like supply and demand just do not apply in healthcare. It because you would think that I'm CVS Caremark, I have 34% of the market. I should be able to get the best pricing out there.
Sure.
And they may, but it's mostly falling on the rebate side. They're able to get better rebates because they have 35, let's just say there's 150 million people. They have about 50 million people that are signed up for their pharmacy benefits. They're going to the drug company and saying, I hold the lives of 50 million people and their access to your medication. And if you
Right.
want access to this market share, you're going to have to, ante up and give us the best rebates you possibly can on your drugs. And this is really what starts the vicious cycle of pricing keep going up by pharma because they have to pay more in rebates to these pharmacy benefit companies. So again, it's a perverse incentive where pharma has to keep raising prices to get more access to market share instead of competition to reduce pricing. And there's a little bit of competition between different manufacturers making different branded products when they're in the same class of drugs to say, okay, well, look, I'm probably competing with them over there. But for the most part, the prices are about the same within a therapeutic category. And then the rebates are really what are ratcheted up to get more access because this list of drugs, as you mentioned, that these pharmacy benefit companies curate are heavily weighted on how much rebates are available to them and see which ones are easier to access for patients. Remove the barriers for these members to get access to your drug, the more you pay me in rebates. And
And
sort of
and
pricing's disconnected from that. And that's sort of the point here.
that makes sense. And one piece that I think is really important, most rebates are a percentage of that MSRP, that list price,
List price.
correct?
That's right.
Most of them are done
Mhm.
that way.
Okay.
So to your earlier point, and I've raised this on this show before, to your earlier point, if you're getting 10% of $100, that's
Mhm.
$10. So
Mhm.
$100 is your MSRP. If you raise that MSRP to $1,000, fundamentally, and again, one of your other points, the laws of economics don't apply. Nothing to do with supply and demand here. We're just talking pricing, independent of all of that.
Mhm.
Now my rebate on $1,000 is $100.
Yep.
So the incentive, if the rebates are structured generally as a percentage of the retail price,
Mhm.
the incentive for pharma is to raise price because the PBM in terms of access, by the way, I'm giving one side of the argument here. Okay.
Yeah.
There is
Yeah.
another side of this argument. So this is one side of the argument.
Yeah.
And I'm trying to be as objective as possible, but just saying um, the PBM by doesn't really care about the list price going up. In fact, they may want it to go up because their rebate dollars grow.
Yeah. Hmm. That's
What
right.
is the evidence for the CVSs and care market that for the big boys that are out there? What is the evidence that they have moved or have a substantial portion of their business in fixed dollar rebates versus percentages?
Great question. I'd just be guessing in the dark if I had told you this. I have no idea what these proprietary contracts with PBMs and manufacturers, how they've shifted over the years. I just know about, the percentage, as you mentioned, as a percentage of list price.
And I don't either, but I will just say that certainly there's no incentive for
Hmm.
them
Right.
necessarily to switch that model.
Sure.
Um, okay, so
So this
back
gets
to you.
Yeah, so this gets to the pricing piece, right? And back to your point about, look, I have this volume, this population, this market share, I have all of these lives, how do I go get the best pricing? And this is where it goes back to the type of drug. So when you have one manufacturer making one medication, our Eliquis example from the beginning, there's no real there's no real manufacturer competition in that market. This is the price and that's what you're going to pay, and you can get a rebate to lower the cost of this drug, and that's really your only option. That's in the branded silo. Similarly, in the specialty silo, the specialty drug silo, with drugs like Humira and Enbrel and Skyrizi and Otezla, so on and so forth. These specialty medications, very expensive. We're talking about upwards of thousands of dollars a month for these medications as a list price. The best option or the best vehicle to help lower your price in the traditional pharmacy benefit space was, I need to go get a rebate. Now I need the biggest rebate possible. And who can go get me the biggest rebates? It's the big boys that can, sort of leverage the best rebate pricing. The only place this doesn't apply is in the generics market. And a generic is, so, Eliquis has a generic, that's its scientific name, if you will. And when that becomes off patent, then you have at least one other manufacturer that enters the marketplace for the first 6 months. And then after that, you have a flood of manufacturers that enter the marketplace. Teva is a good example, Dr. Reddy's. There's all these generic manufacturers that only make generic drugs. That competition, where they're all making the same product, is what pushes the price down. And now you have a drug that could be as cheap as a couple cents a pill instead of dollars per pill. And that's where you don't, there's the volume has no connection to the price of the drug. And so now you can say as CVS, well, you're getting a great rebate on this side, but I'm going to charge you, instead of cents per pill for the generic that could be available in the future of Eliquis, I'm going to charge you dollars per pill. And then I'm going to be able to sort of make this spread when I'm charging dollars to the plan sponsors, whoever they are, and the people are paying for this benefits for their employees, and then paying to the pharmacies cents because they know how much these drugs cost. That spread has been traditionally a large revenue stream for the traditional pharmacy benefit company. So volume doesn't have any play except for rebates. Rebates applies to specialty drugs and brand drugs, but in the generic marketplace where you have multiple manufacturers, that pushes the price down of a generic medication. It's where now volume doesn't matter. It's just the competition in manufacturing that's really pushing the price down. And that's really the key of what, that's not, now there's another price for a drug. It's this, marketplace price of drug. What are you buying it for? What's your purchase price? As we went back to this model with the supply chain, and there's different purchase prices based on how many manufacturers there are for generic medication. So there's the three big buckets. That's all the drugs in the country: generic, brand and specialty. You have your whole med pharma bucket, which is separate outside of pharmacy benefits. And that's really what you're covering and you're trying to decide what to cover, what not to cover. And there's all kinds of complexity in there determining, if there's a generic available, should patients have access to the generic market? This is a great example of the story of insulin. Humalog became, all types of insulin, Humalog, Novolog, Lantus, so on and so forth, long acting, short acting insulins. A lot of insulins have generics available in the marketplace, but very, very few people, when they first became available as generic, had access to that, because who was limiting or saying what drugs you had access to? The pharmacy benefits company. So when you showed your insurance card at the pharmacy, they would say, nope, we're not going to give you access to the generic. You have to go get the brand drug. Why do we prefer the brand drug? Goes back to your point about the rebates. We're getting rebates on the brand drugs. We don't get rebates on the generic drugs, even though that may be cheaper overall for the patient. They have to pay a higher copay for a brand drug versus a generic drug. And it may overall be less expensive for a company to utilize these generic drugs. And that's really, we can get into that a little bit later, but that sort of goes into this, what happens and why they have access.
So at the risk of losing the 3 listeners that have stayed with us this far, I have one other question, and it's around generics. So I think most people listening understand that a drug that's developed and that comes onto the market has a patent life. And so for it to have its exclusive life and having its brand name and all of that in the marketplace without any competitors, there's a
Mhm.
limited time. And
Yep.
that time frame varies because I think the patent starts once the compound is discovered, but it's very early in the in
Yeah.
the
That's
in
right.
the process.
That's
It's
right.
not like the product gets approved and then the patent
Correct.
clock starts. It's much earlier than that.
Correct.
So my question around generics is, okay, so the PBM, there's potential for them to be making money on these generics as well. Just retail has the ability to do that. Is it McKesson that is making the choice to say, who has the biggest catalog and who's the most reliable distributor of generics, such that I am going to have an exclusive arrangement with Dr. Reddy's or with whoever the generic company is, or are they just buying what's available? In other words, to what degree does a generic company have a say so in all of this and whether their generic products are being used with regularity?
You're absolutely right, John. The wholesalers are really who are negotiating directly with these generic manufacturers. And they're the ones that are negotiating between generic manufacturers to try to push the price on a unit cost basis as low as possible. And then it also has to go back to access. So they need, redundancy in the generics marketplace to say, look, if one company shuts down, we'll still have access to others, or we need access to, 4 or 5 different manufacturers of the same generic drug because there's slight variations in it. We need to make sure the pharmacies have access to them, and they're ordering, specific generic manufacturers. So we need to keep that in stock. But for the most part, it's these wholesalers that are negotiating directly with these generic manufacturers to make sure they're stocked, so that when the pharmacy orders it and they see the pricing, they're going to pick the one that's most, cost effective for them. So that, based on, that's just what they're buying it for. The only thing that a pharmacy has control over is what they buy the drugs for. And that's even limited in terms of how cheaply they can buy drugs for. The other side of this is, just like everyone else in healthcare, what am I going to get reimbursed from the insurance company? Because I need to buy as cheaply as possible, because I could get reimbursed half of what I'm expecting. And I got to have enough margin there to make a viable business. And that's really the problem that a lot of these local independent pharmacies are running into. The wall that they're hitting is, I can only buy it for so cheap. And then even beyond that, I'm getting reimbursed below what I can buy it for from these insurance companies. And that's driving many of them out of business.
So this is the last piece, and then I want to get to Mako.
Yeah.
The last piece of this is, what is the just pick any drug or pick something fictitious. What does the reimbursement process then look like? What is, if we follow the money and we use some numbers here, what does the reimbursement price look like for the pharmacy, or and what is the window that the employer sees everything, because they're stroking a check for this at some point?
Right.
What are they seeing what's going on in
Right.
this whole process?
Depends on the drug type, but this is where transparency has been so important, especially these last couple of years. Historically, the employers have not seen what the pharmacy gets paid for a medication. They only see what they get charged. And a lot of the times, as an employer, if you have a small benefits division, you're just going to be overwhelmed and say, you just pay the bill, right? There's no time to figure out or understand if we're getting overcharged or underpaid. States, on the other hand, have had the opportunity to reference what they're getting charged in state Medicaid programs and understand if there's been a significant markup in the medication. But from an
Of
employer
course.
perspective, it's really been hidden. And that's really where, when people talk about pharmacy benefits, it's a black box because they just don't know what happens in there. And it's really, really complex in terms of all the different relationships and all the different contractual agreements that help finally determine the price of a medication. Where you buy it from is really important as well. And so employers pay one price, they pay the bill that they get from their pharmacy benefits company. And then on the other hand, a pharmacy gets to know almost instantaneously what they'll get paid for a drug. So when you go into a pharmacy, a local pharmacy, particularly, whether it's a national chain or a local mom and pop, doesn't really matter. They're taking your prescription and your insurance card information and they're running it through their system, through the pharmacy management system that they have, whichever one they have. And then instantaneously it goes to the pharmacy benefits company's system and it pushes back a price to them that says, look, John owes this copay or cost share, depending on what plan he's enrolled in. And you, pharmacy, will get paid X amount of dollars for this medication. And so instantaneously, the pharmacy knows I just bought this drug for $10 a unit cost, and I'm getting paid $8 a unit cost. So almost instantly, they'll see a negative 20% margin on that medication after they run it. They're just minutes as you're standing there and they run it through the system. And that's when they have to go hunt down and see if they can buy the drug for cheaper, which always an option if it's a generic manufacturer, a generic medication, because they can go sort of hunt and find out. And a lot of the time of pharmacies now is just hunting and trying to find the cheapest cost medication so that they can sort of break even or make a small profit on these drugs.
So wait a minute. Let's just the generic side of things.
Yeah.
The pharmacy manager is going to be looking at all. Let's just use amoxicillin,
Yeah.
clavulanic
Mhm.
acid, right?
Yeah. Mhm.
Very common,
Mhm.
augment. They're going to look at how at all the different places that they can buy that generic drug to try to find the absolute best price in that moment. So
Yeah. Yes.
help me with that. Yeah.
Yeah, so they're gonna. It's not technically in that moment, but what they're going to do is take their system and generate a report that says, of all the prescriptions that we process today that haven't already been sold, do we need to go find a better place to go buy these drugs for? And then they're taking that report and then they're going back and at the end of every day they're saying, okay, where can we go buy these drugs? They're doing a force bartering system to figure out where they can go buy this drugs for much cheaper. So yeah, not instantaneously, but yes, at the end of each day, that their normal business process to go find drugs as cheap as possible.
And I'm imagining that there's a time delay in terms of the reimbursement. So they're going to be submitting a claim. That
Mhm,
pharmacy is going to submit a claim to the PBM after
mhm.
that has been filled. And they're asking for a reimbursement. Maybe there's a stocking fee. Maybe there's other kind of one-time fee or associated with the transaction. Are they allowing that for pharmacies, or I'm just trying to think? Nothing, none of that. Okay.
Nothing. Yeah, nothing. Their total reimbursement is on that claim. That's all they
Okay.
get.
So, all right. Now let's move to you. How you're what you're focused on in your company and how it's different, how you're addressing um, sort of like the pricing issues and the value issues in the marketplace. How are you attacking and improving value?
So where MakeRx started was to go to the marketplace and for at least 85% of all prescriptions in the country are dispensed as generic medications. And so we said, look, let's start with the lion's share of medications that are dispensed in the country, and let's show employers what pharmacies are buying these drugs for, whether it's a penny unit cost, whether it's a $5, $10, $100, $1,000 unit cost. we're going to transparently show these plan sponsors what pharmacies are buying this drug for. So we're going to get to a unit cost basis. That's an average national average price, acquisition price for a pharmacy. And that was that was sort of unique at the time. This was in 2018, where it had never been done in the employer market before we had created this model and wanted to take it there. And then we recruited pharmacies to say, would you be interested in this cost plus, what we had called it at the time, cost plus reimbursement model, where it was, sort of, it had already gotten bad by 2018, but they, overwhelmingly said, yes, we would love to know exactly what we're going to make on a drug. No one's going to come back in and claw back fees from us or claw back fees from the patient. It's all just going to be open and really transparent for us. We would love that. So we signed up about 19,000 local pharmacies at the time to sign up for this model. So now we had a network. We had pharmacies all over the country. That's about a third of the pharmacies, that all the pharmacies in the country that signed up, and we had access in various different points. And most of them were local mom and pop pharmacies. We also had a huge grocer chain that signed up a year or two later as well to continue to add to that network. And now we have access. So that's really primarily what we needed if we were going to go to these employer groups for. And we said, look, now you get to see, employer, transparently, you get access to all your prescription data, all your RX data. You get to see whatever you want. This is all your data. You own it, and we'll be able to share it with you. And then when you see a generic drug on your list, you'll be able to see exactly what that costs the pharmacy. Plus, you're going to pay them a higher dispensing fee. So this dispensing fee is really what pharmacies started getting into, the claims started growing into when there's been counseling and more additional services required of pharmacies to get a medication off the shelf and to a patient. And so that dispensing fee, instead of being 75 cents or 65 cents, we were paying them $8 or $9 to dispense that medication. And that's when people started comparing, and the employer said, okay, well, look, why am I paying $9 or $10 for this medication when I could be getting a 65, I just want to spend 65 cents to dispense this drug to a patient, to one of our members. And we said, and that's where then we went into and said, well, if you don't know what the cost of this drug is, you could get charged anything from a pharmacy benefit company, where they may be charging you for 90% of claims, 65 cents, but then you get charged hundreds of dollars for a generic that's only available for a couple dollars. And that's really, there's a very few amount of claims that charge you a lot. And we're just going to come to the table and tell you exactly what the price is every single time. There's not going to be this variation. There's not going to be hidden claims where you get overcharged, because you'll see exactly what these drugs were costing at the pharmacy. So cost plus local pharmacy network. Go ahead.
Let me ask you a question and tell me if what I'm saying makes sense. The argument for transparency to the employer that you're talking about, the argument for this feels like, I don't know, 10, 20 years ago when you're buying a car, all of actually knowing what the dealer paid, or actually knowing what other kind of incentives, right? To arm the consumer with more or better negotiating power. Now the consumer can say, all right, well, this truck cost me 50, or you're telling me it's $50,000 for this truck. But I know that you paid 40 for it. And I understand you're a dealership, you got to make money, but I'm not paying you a dollar over 42K, because 50 years ago, whatever, none of that information was available to the public. Now, through various reasons, is that the similar argument for giving employers transparency? And the reason why I'm asking before you answer is because I've thought about this, and I'm wondering, why does the employer care? At some level, if I'm the employer, I'm the employer benefit manager, and I'm spending $10 million a year on pharmacy, I'm just going to say, you need to do better. And you say that you're this PBM that has all this buying power and you can negotiate better. I'm not paying these prices anymore. So go figure out how to make it cheaper for me. I don't care how much you're paying for it. I don't care what your deal is. All I know is that if you don't make a better deal, I'm going with somebody else. What do you say to that argument?
Historically, the way that employers got a better deal from traditional pharmacy benefit companies is they would come back to the table with a larger rebate amount. And they would tell you, well, instead of getting $10 million in rebates this year, or sorry, $1 million in rebates this year, we're going to give you $1.5 or $2 million in rebates. The the issue there is really a educational one, in that if you don't understand the system, you don't know where the money's coming from. So yeah, you're getting a better rebate, you're getting a bigger check at the end of the year, but you don't realize that you're paying for that money and you're getting overcharged in these really small, tiny pockets that you can't find unless you're digging deep and you're doing a forensic analysis on your claims level. Whereas the alternative here is, we're going to start showing you all the prices and you'll be able to tell, we'll be able to go back to you and tell you exactly what the price is for these drugs. And not only that, but that's going to help you're never going to get overcharged on a generic medication, because that's going to be the price that you're going to pay. And since we're covering the cost of what the pharmacies are buying for, this is even our price to buy for. This is what the pharmacies are buying it for. You're covering their cost. The value of this is really that relationship that pharmacy has with your member, that how they're taking care of more than just that medication. There's chronic conditions involved here, where if a pharmacy supported to get, and coordinating care with the physician, making sure that they understand how to use their medications, the side effects, to be adherent to it, and then to also help educate them in addition to what they got at their doctor's office about how to manage their conditions, you now have a long-term mechanism to help control these costs. And yes, you're seeing a dollar amount on these drug costs that are really, really expensive. And now it's only got the acceleration of the pharmacy costs. We're talking about 40% of healthcare spend is now on pharmacy costs, and it's all gone higher and higher. If we don't take care of the basics and show you how you're not getting taken advantage of on the basics, we're not even going to be able to get to the branded specialty drugs that are representing higher and higher costs every year for employers. They're crippling some of these small employers. So American Airlines is going to be fine in terms of they have a whole team managing pharmacy benefits and benefits in general. But the smaller guys, the people that are less than 1,000 employees, they don't have an entire benefits team. They have maybe one person taking care of benefits. We're here to help educate, guide them, coach them, consult them, advise them on where they're really, where they can optimize their pharmacy benefits to then all aligned to this total cost of care. That may be different than what you were expecting, but that's certainly the
No,
approach that we
that's
take.
super, super helpful. So with MakoRx, you're looking to, now you have the network. You
Mhm.
told me the story about how you built out the network and in the earlier days. What is ultimately your value proposition that you're going to market with today?
Yeah. So we established a baseline price for these medications. We've established value at paying for these drugs when they're getting dispensed from local pharmacies. We encourage members to go to their local pharmacy to get. There's nothing special about getting your drugs in the mail. In fact, if they're delayed or they never arrive, you still have to walk into a local pharmacy. So have a relationship with your local pharmacy, and that there's a tremendous amount of value there. There's a tremendous amount of customer service available at any local pharmacy you go to. But now you have an incentive to go to a local pharmacy, because our preferred pharmacies, you get lower cost or low copays. You get the standard cost or standard copays at any other pharmacy in the country. And now we're going to go and incentivize generic medication. So a net cost formulary that says insulin, if there is a generic version of insulin available in the marketplace, you will have access to that. It will be cheaper for the employer and cheaper for the member at the pharmacy. Same thing with Humira. Humira's biosimilar came out last year. We had 96% of our patient population accessing the biosimilar when it came out last year, when you had a lot of restrictions on access to the biosimilar. And what we've seen is within the first year, 30 to 40% savings on their drug costs, just from adopting a model that's transparent, that's clear, that incentivizes generics and biosimilars first. And that's without us even getting into the details. Now we have, okay, well, this is the baseline price. What can we now do with the employers in mind, with the pharmacy chain, supply chain in mind, to access more savings on the brand side, more savings on the specialty side that doesn't rely on rebates? Our mission is to essentially get rid of rebates from the system. If there were, it would just make things a lot easier. And we're doing that individually for each of our employer groups by saying, okay, well, let's find a better source to get branded drugs that doesn't rely on the rebates. Some employers that want to have access to international sourcing or personal importation, we can provide access to them to get drugs that are basically half the price of drugs in the US. We have access to a program that we're setting up that gets people access to federal pricing for medication, so on and so forth, for specialty medications. we have a cost plus solution on specialty that helps allow savings on in addition to just the traditional means and traditional model. And so now we've gone and sort of ratcheted up. Level 2, level 3 is where's the savings programs that can help optimize brand and specialty drugs now that we got a great baseline on all the drugs and you know what the cost basis is.
So I'm curious. You had mentioned 2018 as you're establishing the. I think I got that right when you're
Yeah.
establishing this network.
Mhm.
Um, it seems to me that around that time that there's a lot more interest in the pharmacy space. I'm just going to say generally,
Mhm.
and different companies trying to attack this pharmacy benefit problem,
Mhm.
whether it means, the Civica RXs of the world or, Mark Cuban cost plus drug company. And, you know, was there anything, I don't know, 2015, 2016 timeframe, was there anything that happened from a technology standpoint, from a legal standpoint? Was there anything that happened that kind of kick this round of innovation into gear on the pharmacy side of things? I'm just, sort of like retrospectively, here we are going into 25,
Yeah.
looking back 10 years. I'm just wondering if there was something, or if it was just that, look, drugs are getting more expensive, more specialty drugs with these $10,000 a month price tags, and we have to start paying attention. And so it was kind of like, necessity is the mother of invention, as the saying
Exactly.
goes, right? Was it more of that, or was there any changes that happened in the, availability of information around that time?
In addition to what you just mentioned, John, in terms of the price tag for medications going up and specialty just exploding in terms of the number of drugs available in specialty or the number of
Right.
drugs categorized as specialty and the price tag just skyrocketing and people started waking up and paying attention because when you looked at healthcare costs, traditionally pharmacy was under 15% or under 18%. And it was just, okay, it's there, but it wasn't a big concern. People really focused on the medical spend to help lower their healthcare costs. Now, and the second piece here that I think contributed, and this was sort of what led to the Affordable Care Act goes into effect 2010. And from 2010 to 2015 to 2016, you have this vertical consolidation of we can't make money in the medical space because MLR is restricted. So we need to find other sources of revenue to help, just help continue growing these publicly traded companies. And that sort of led to that consolidation and that really led to people saying, okay, well, if these companies are becoming behemoths, and this is going to cause additional pricing, you know, rise rise in drug pricing that we're going to have to address. So I don't know if there's anything specific, but those are sort of the larger trends that sort of led up to at the end of that decade creating this environment that people needed to figure out. And then short drug shortages. So we had a lot of drug shortages becoming more and more of a problem as this consolidation happened. And as we had consolidation in the supply chain market and pushing prices down to sort of bottom dollar, it created manufacturing that was unsustainable because there wasn't enough money to support high quality manufacturing process. And so then that led Civica to say, okay, we're going to have to address this problem. If hospitals are having a hard time getting IV bags, we're going to have to figure that problem out. And then Mark Cuban gets into the game after they realize that drug costs are just skyrocketing. They also wanted to address some of the drug shortages in the industry. Um, and that's when, sort of all this environment became right to for some innovation.
Sure, sure. It's one of those things where, and you mentioned back in 2010, and I've said this before in different contexts, but the impact of Obamacare or the Affordable Care Act is so much bigger than, oh, you're 26 and you can
Yeah.
stay on your parent, 25 stay on your
Yeah.
parents, or we have these insurance exchanges. There's so much more innovation,
Yeah.
so much more positive and external and negative external
Hmm.
externalities that came out of that legislation that people just don't talk about it.
Hmm.
But that's, the way that you described that time period is entirely accurate. I mean, it just so
Yeah.
maybe a conversation for another day. The last question I have for you, because I know we've gone over what I had intended. I hope you're still in it. I'm still enjoying the conversation, but
Yeah. There's so much
I,
more we can talk about.
there is so much more, and maybe we'll have a part two,
Sure.
down the line. But now that we're pretty much so post election and looking into 2025, regardless of what may have happened,
Hmm.
and who you may have been voting for,
Hmm.
what are you seeing, in pharmacy, and specifically in terms of reimbursement and distribution, all the things that we've been talking about? What do you see are the things to look for in 2025? What am I going to be writing about in March and in June and whatever? Like any change? Are you seeing anything maybe that's going to come out of the Senate, or
Hmm.
looking at investigating PBMs? Like, what do you see in your crystal ball? Hate to put you on the spot like this, Vinay, but what do you think? What's something we should be looking for in 25 and 26?
Here's one thing that's really surprised me. It does not matter your political affiliation or what side of the aisle you're on. Everyone, everyone has this laser focus against either pharma or the pharmacy benefits companies. I mean, just this past 3 years, we've seen increased scrutiny. Every year, it seems like we go through a new Congress that says we're going to focus hearings and call these CEOs up, and we're going to question
We've been
them.
writing about it, so yeah. I mean, yeah,
And so I think that continues. Doesn't matter who's in office, who's in power, what side, what political parties in power. That will
agreed.
continue. The scrutiny, the attention, because costs are only going to go up. Next year is not going to be any better than this year. We were told of in the fall of 23, we were told that here's how much healthcare prices are going to increase in 24, and now we're going into 25, and we're seeing the same thing. Here's how much healthcare prices are going to be increasing
Right.
again, and it's going to become unsustainable. Either we're going to have a group of people in the country that just can't access or afford healthcare anymore, or the whole thing implodes, or we get some sort of solution that's supported by some third party that says, here's how we're going to continue the path we're on, although I see it as unsustainable. And so from a federal perspective, we're going to continue to see increased scrutiny on drug prices. We're going to see increased scrutiny on pharmacy benefit companies and the role that they play in drug prices, whether that's good or bad. Uncovering a lot of that, the CEA sort of started this path in 2021 or 22 with creating more transparency and accountability for employer groups. But at the end of the day, I think it's going to be difficult for the government to make any significant or meaningful change. There's too many jobs, there's too much money in healthcare. It's a political firecracker to try to change healthcare too much too quickly, although there's several pieces of legislation introduced that will help address some of this pricing transparency and sort of trying to get to a better affordability uh, place for the patients who need it most. And so, that's just a little bit of what I see coming in. And it's going to take a little while, so it won't be until, as you said, March or April or May until we start seeing some significant motion through Congress after they get settled in for the new year. But there's still a lot to come. Healthcare seems like there's a new story in healthcare every week that someone needs to be focusing on and figure out, because it's a seismic change. It's not just small changes. When you hear about these news stories, it's, you know, CVS changing their whole executive team because they need to figure out what to do. And Vermont, the state of Vermont, going essentially declaring that their healthcare system will not be able to sustain itself in a year or two, and One Care Vermont going out of business. And there's a tremendous story there in terms of what's Vermont going to do about their healthcare costs. The most number of people in the country insured there, but the least people that can afford it because it's so expensive.
Yeah. Yeah. Well, we're this podcast. First, I will say it's job security. I've said that before. This all these changes is great for Darwin Research Group, because people call us and say, "What's going on?" and then we have to answer those questions. So that's that's good. Never a lack
That's
of
right.
things to do, right?
Right.
Well, I hope that we have an opportunity to talk again. I feel like we've been talking for an hour, Vinay, and that we have scratched the surface.
That's
So
right.
I hope you'll come back
Oh, would
maybe
love
next
to.
next season and talk more in detail about, who knows, maybe we'll see something in the first or second quarter that'd be worth talking about here on Healthcare Round. So How do people get a hold of you? Want to learn more about MakoRx, or just want to talk to you about drug prices and all of the, how do they find you?
Best place to find us is on our website, MakoRx.com. There's a form that they can fill out. Our phone number's on there as well. They can reach out to us and just ask for me, and or they can email me, vinay.patel@MakoRx.com. Would love to have a conversation with anyone who's interested in shaking things up in healthcare. It's been a wonderful conversation, John. I completely agree with you. Can't wait to do it again. I'm happy to be on whenever you'll have me again. And Ken, thank you for a conversation that's been engaging. Haven't had an engaging conversation in a long time.
Yeah, thank you so much. This has been great. So that'll do it for another episode of Healthcare Rounds. Again, I'm John Marchica, CEO of Darwin Research Group. Today, we've been talking with Vinay Patel of MakoRx. Do us a favor. I always ask this. Take the time, if you like what you're hearing, rate us, review us, subscribe, all those things that your podcast people say. Please do so. We really appreciate it. Thanks again. We'll see you next round.